Hello, everyone. After this last two episodes of cardiac function and cardiac markers, we have thought of delivering our discussion on another new chapter or rather a system. We call it a liver function test. So, as you know, our aim is mostly to deliver the undergraduate and most postgraduate students and the lab personnel the basics of the lab sciences and interpretations. So, we will first deal with these basic sciences like liver function test, renal function test, the other problems, and later on we'll go with the advanced technology. So, let's start with the liver function test. And to start with the liver function test, I would like to check that. See, this is the liver anatomy, as all of you know. This is how the liver anatomy looks like, and this is what the inferior vena cava artery and how the gallbladder is placed and how the common bile duct is formed with joining this bile ducts, and therefore how the liver is actually working. So, before knowing this liver function test, it is better to have a quick look on the anatomy. So now we go for the concept of organ function test. So if we talk about some organ function test, what is that? That means these are group of tests which actually uh, gives an idea of the organ functioning or the system function. So therefore you have lots of organ function tests, but the commonest is a liver function test, renal function test, and thyroid function test. Also, you can have some pancreatic or pulmonary function test as well. But in general, these are most common and most popular of the function tests. So before we go for the liver function test, that means we are going to judge through a battery of tests what are the functions of the liver, whether the liver is healthy or unhealthy. So before we go for the liver function test, we must know what are the principal functions the liver have. So one of these is metabolic functions. As you know, liver is the, should I say, the uh, kitchen of our body. So it is all the metabolic functions that taken place. Also detoxification functions, hematological functions, and excretory functions. I'm coming later on describing one after another. So components of liver function test as a whole, we consider about the total bilirubin, the direct and indirect bilirubin, the enzymes, we call liver enzymes. That means the AST, the ALT, alkaline phosphatase, gamma glutamate transferase, and total protein albumin Ag ratio. And also sometimes we consider prothrombin time as the liver function test also, because that describes the hematological functions, whether they are doing properly or not. And urine tests also, we have certain tests like urine bile or bile pigments and urine urobilinogen. These are all consist of a liver function test in general, but you may add on one or two more tests to give more specific functions, to locate more specific functions of the liver. So therefore, the functions of the liver, that as a whole, how it looks at are metabolic functions. As you know, the carbohydrate metabolism, the protein metabolism, fat metabolism, what kind of metabolism it may be, all metabolism is actually cooked in liver. So liver is basically the storehouse of all the functions. Detoxification functions, yes, because of its metabolic activity or metabolically it's so active or an organ, so it causes some detoxification. Particularly, we generate lots of conversions, ammonia. The ammonia is converted to urea in liver only, one of the principal detoxification factors, function. Also, bilirubin metabolism, xenobiotic metabolism, and phagocytosis by Kupffer cells, they are all as basically detoxification functions. The hematological functions are, that is, synthesis of clotting factors. As you know, all the clotting factors, most of them are synthesized in liver. And also in embryo stage, hematopoiesis is also taken care by liver. And excretory function is what? The excretion of bile. So bile formation and excretion serves an excretory function by the liver. So liver serves all the functions at a go, and one of the most important organ of our body. So therefore, the liver function test means that, as I told you, the battery of tests. So which actually detects what? the condition of your liver, if there is any liver disease present. If there is any liver disease present, what kind of disease it is? That means types of liver disease can be distinguished. Not only that, the extent of liver disease, whether it's a preliminary condition or a extensive liver damage, can be also detected. Sometimes, with the response to treatment, we also do LFTs, and also most importantly, most of the drugs are metabolized through liver. So whenever the drugs are metabolized through liver, so before administering the drugs, we sometimes do liver function test to know that my liver is having strong function or not to metabolize that drug. Sometimes some of the drugs are very toxic. So for those cases, hepatotoxic drugs, before administering those, we also check the LFTs. Now, bilirubin metabolism, as you know, this is not very complex thing. That is a breakdown of hemoglobin in blood in 80 to 85% of bilirubin, and therefore, from myoglobin is 15 to 20%. So these are what we are breakdown of hemoglobin. Fine. So once a bilirubin is formed, a major problem with bilirubin is not water soluble. So we know some of the products, they are hydrophilic, some of them are hydrophobic. So particularly neutrals cannot be dissolved in water, organic compounds. So therefore they need to be water soluble. And to make it water soluble, you have to add some polar groups with the non-polar products. So bilirubin, being a non-polar one, cannot be dissolved in blood. So it takes help of albumin. It is conjugated with albumin and goes to liver. Now once it's taken up by the liver, it needs to make this bilirubin a water soluble product. So that is called the glucuronidation. So what happens? Bilirubin is getting conjugated with two molecules of glucuronic acid and therefore produces bilirubin diglucuronide. Now this bilirubin diglucuronide is absolutely water soluble. Now it is because it is water soluble, it dissolves in the bile and therefore excretes in the intestine. And on the product in the intestine, it forms urobilinogen and some part is excreted in UT. But the major thing is that making a non-polar bilirubin, which is water insoluble, to a polar bilirubin diglucuronide, this glucuronidation is the main function of bilirubin metabolism by the liver. So as you get it in a more non-complex way, that is hemolysis or whatsoever that causes a bilirubin formation. Bilirubin with the help of albumin comes here, which is totally unconjugated bilirubin. Now, in two steps, it provides a conjugated bilirubin and it goes to biliary system. In the gut, it produces urobilinogen by the gut bacteria and it is getting absorbed through the portal vein and released by kidney. So these are the bilirubin metabolism is a nutshell. So quantitation of bilirubin can be done by diazo reaction. So involves a reaction of bilirubin with diazotized sulfonilic acid and the reddish purple formation of production is azobilirubin. So what happens? When in presence of alcohol, the bilirubin reacts, that means it's a total fraction of bilirubin. When in absence of alcohol, it reacts, that means it's a water-soluble fraction or the conjugated bilirubin portion. Rest, you can do a calculation to get out the unconjugated bilirubin. This diazo reaction was first introduced by Ehrlich in 1883. Then Vanderberg modified it in 1916, and then Jaundice and Goff has modified it in 1938. So now the other tests, other than this test or chemistry test, you can also detect bilirubin with the help of an HPLC, which on the basis of its charge differentiates the bilirubin fraction. The unconjugated bilirubin is the first one, is alpha bilirubin. Beta is the monoconjugated, that means bilirubin monoglucuronide. When one molecule of glucuronide has been added, other is yet to be added, it's called the beta fraction. Delta fraction is a total bilirubin, a conjugated bilirubin or bilirubin diglucuronide. So gamma. And delta fraction is that portion of bilirubin which is actually conjugated with albumin and moving in the blood is about to taken up by the liver. So these are the alpha, beta, gamma, and delta, or the four fractions. So you can also use it by enzymatic method using bilirubin oxidase when it is oxidized to biliverdin, and therefore this purple color produces a colorless product, and there is a decrease in absorbance between or either you measure it in 425 or 460 nanometer. By this way you also can measure. And urine bilirubin can only be present in conjugated bilirubin. So whenever there is an urine bilirubin, it has always been a conjugated one. What is called hyperbilirubinemia and jaundice? There is a lack of consumption. Jaundice does not say about hyperbilirubinemia. Jaundice refers to yellow discoloration of skin. Usually, normal level of bilirubin is 0.3 to 1. So whenever it goes above 1, we call it hyperbilirubinemia. But it may or may not be evident on coloration of skin. So jaundice means yellowish coloration of skin. Mind it, jaundice is not a disease. It is a rather symptom. So whenever your body becomes yellow, you call it a jaundice. So therefore, hyperbilirubinemia is the condition of the status of this molecule, whether it is high or not. But jaundice means the symptoms which is showing the yellow coloration. Test of urine bilirubin, as you know, it is usually used trichloroacetic acid, 10% ferric chloride, and water. And therefore, it is a greenish color appearance happens when there is a ferric chloride. He is oxidizing the bilirubin. So it is usually conjugated bilirubin that reacts it because they are water soluble. Whenever you find a water soluble bilirubin in your urine, this must be a conjugated bilirubin, because if a conjugated bilirubin moves too much in the blood, that is excreted by your kidney, and therefore you can get urine bilirubin positive in those cases. Another one, urine urobilinogen, which is called enriched aldehyde test. So this actually produces a pink red coloration on positive reaction. So the reagents are, I'm not discussing much about it, but what is the clinical significance? Why it is called a hemolytic jaundice? Because in obstructive jaundice, you will not get a urine irregularity. That is very, very important thing. So how you do the test? 5 ml urine with enriched reagent, mix and allow to stand for 10 minutes. And then saturated sodium acetic acid is 5 ml added and mixed. And then 5 ml chloroform mixed and added and shaken vigorously. You will get a pink color formation, which is proving positive for urobilinogen. So before that, I will say, what is the significance of urobilinogen? You have to understand that urobilinogens, when bilirubin diglucuronide, that goes from the bile to the gut. In the gut system, in the gut bacteria, they produce urobilinogen from the bilirubin. And therefore, it gets absorbed from the gut through portal vein. So if there is any obstructive jaundice, the bile will not come to the gut. So there will be no urobilinogen formation. But if there is an excess urobilinogen formation, that means the bilirubin production is prehepatic. There is excess prehepatic bilirubin production, and there is no obstruction in the outlet of the biliary system. So excess urobilinogen always stands for a hemolytic jaundice. Eldridge test I have told. There are certain excretory function of liver tests are also there, like BSP test, which is IV injected in 5 mg per kg body weight. But if it is more than 5% retained after 2 hours, that means the excretory function of bile or liver is damaged. Similarly, detoxification function of liver can be detected with the hippuric acid concentration. So if there is a hippuric acid more than 4.5 gram excreted in urine, then it is fine. But if it is less than 3 gram per day, that condition means the liver function on detoxification is not functioning properly, and there is an impaired liver function. It is another one, as you know, that it is a glycoprotein which is synthesized by the liver, prothrombin. And also there are other factors of clotting factor like 1, 2, 5, 7, 9, and 10. They are produced in liver. So whenever there is a liver failure or liver problem, these clotting factors do not act properly, leading to high prothrombin time. Usually it comes between 11 to 16 seconds. But if it is going more than that, that means the liver cannot function these clotting factors properly. So there is a liver hematology or coagulation factor production is diminished. Similarly, in obstructive jaundice, what happens? In obstructive jaundice, bile cannot come to the large gut. So what happens? A, D, E, K, they are fat-soluble vitamins. So unless until they form a micelle with a bile, they cannot be absorbed in the blood. So what happens? In obstructive jaundice, we will sometimes get appetite affected because of vitamin K deficiency. You might have to give an IV vitamin K or IM vitamin K to get rid of this problem. This happens because the bile does not come to the gut, and therefore the vitamin K cannot be absorbed from gut to blood. So these are the hematological functions can be assessed through this. Serum albumin is a high T-half, long half-life, that is around 3 weeks. So any condition, unless there is an acute loss of albumin, loss of production or lack of production cannot initially produce a low albumin or albumin deficiency. So therefore, you will not get in acute liver disease conditions. You will get in liver disease conditions because it is produced in liver. It is synthesized in liver. But those in cause of chronic liver disease, when liver is sick for a long time, so production of albumin gradually diminishes. And when they have a good storage, as they have a half-life of more than 3 weeks, so the diminution or depletion of storage, that takes time to happen. So therefore, albumin always will find albumin low or AG ratio reverse in case of chronic diseases. But there are conditions where albumin can be low, like malnutrition, nephrotic syndrome, protein-losing enteropathy, where huge loss of albumin can lead to an albumin deficiency. But when it comes to a liver function, it is usually found in chronic liver disease. Now you talk about the liver enzymes. Mostly the liver enzymes, we talk about 4. These are AST, ALT, alkaline phosphatase, and gamma-glutamyl transferase. But also another one we add, the number 5, that is a 5-nucleotidase. These are the enzymes which are mostly tested in liver function tests. When enzyme elevated in liver damage, they are usually either ALT or AST. Sometimes LDH and isocitrate dehydrogenase are also elevated, but we usually depend on AST and ALT. Enzyme elevated in serum cholestasis. These are alkaline phosphatase, nucleotidase, or GGT. They increase in cholestasis. So aminotransferases, they are aspartate aminotransferase and alanine aminotransferase. They are the enzymes which transfer amino groups particularly. So that is why they are called aminotransferase. So they are mostly present in hepatocytes, and that is why whenever there is a liver injury, acute or chronic, they get out in the blood. So usually that remains in the liver, but is usually comes out of the blood as increased enzymatic activity are found in the blood when there is a liver injury. So that means acute or chronic, so whatsoever. These are the 2 enzyme functions. AST, that cause glutamic acid and oxaloacetic acid to alpha-ketoglutarate and aspartate. For ALT, the glutamic acid and pyruvic acid converts to alpha-ketoglutarate and alanine. In both the cases, there are amino group transferase. Most important tissue distribution. ALT, the principal source is liver. Very much source is liver. So ALT is more specific of a liver injury. But AST, the principal sources are mostly 3: liver, heart, and skeletal muscle. So any injury in liver, heart, or skeletal muscle can lead to a rise on AST. AST to the other side is less specific than ALT. And ALT, not only it is more specific, but also it contains more in amount in liver. So normal levels are usually this 6 to 30, 8 to 34, and normal AST ratio is usually 0.8 to 1, more or less of similar amount they should be. What happens in viral hepatitis? You will expect a 10 to 100-fold rises of the enzymes, but in viral hepatitis, ALT is much more raised than AST. So the AST-ALT ratio usually goes as low as 1/4 because ALT being more sensitive in viral hepatitis that releases in the blood much more than AST. But gradually with the chronic liver disease comes up, when the liver disease becomes chronic, the AST is more than ALT gradually. So therefore, in chronic liver disease and alcoholic liver disease, you will get the AST-ALT ratio maybe as high as 2. And in cholestatic disease also, they have certain amount of rise certain times. Alkaline phosphatase is mostly rising extrahepatic or intrahepatic, whatever may be the obstructions. So therefore, in biliary bile duct stone or any tumor obstructs the bile duct, there is a high rise of alkaline phosphatase. But the major problem with alkaline phosphatase is that that is also not very specific. They rise also to some extent with other things like pregnancy or other bone injury. They can also rise. 5' nucleotides is more specific obstructive jaundice marker. Mostly in extrahepatic cholestasis, they get raised. Gamma glutamine transferase is another one which is mostly present in PCT of kidney, then in liver, pancreas, and intestine, but is a very, very sensitive indicator of obstructive liver disease. So there is whether there is an obstructive jaundice that cause a high rise. And there is another very specific one is a very sensitive marker of alcoholic liver disease. So therefore, whenever there is an alcoholic liver disease or a chronic hepatitis C virus infection, etc., you will get a rise in GGT. So mostly they are in case of cholestasis, then alcoholic liver disease, then some metastatic liver disease maybe, and some chronic HCV, hepatitis C virus infection also, GGT comes rise. But most we depend on it. When alcoholic liver disease is one of the most sensitive markers. So in a nutshell, but you have to understand this very carefully. This one is what we have divided this liver disease into acute hepatitis, chronic hepatitis, hemolytic, that is prehepatic, and obstructive in post-hepatic. In acute or hepatic jaundice, you may get a total bilirubin raised with equally raise of conjugated and unconjugated bilirubin, not very raised ALP, but very much high ALT, and there will be a high ALT-AST ratio because ALT and AST both will be raised. ALT will be raised more than AST. GGT will be also raised in case of initial phases, but there will be no difference noted in albumin, globulin, or total AG ratio. For some meantime, you may or may not find increase because there is a hepatitis, liver is not very healthy, so you may get a raised hepat from meantime for that because the clotting factors are not produced. The most important thing is that during the excessive release of the total initial phase, the total bilirubin is released from the hepatocyte. And there will be a mixture of conjugated and unconjugated because that time the process was going on when the liver was attacked by the hepatitis and it is causing damage of the liver cells. Similarly, in chronic hepatitis, when this hepatitis, HCV or other infections, when there is a chronic hepatitis inflammation but going on for a long time, so in those cases you will get the raised ALP, AST, but sometimes you may get a ALT-AST ratio more or less around 1, but both are increased. But what you will get here, very importantly, albumin raised and globulin is high, leading to reversed AG ratio. This happens because the hepatitis or hepatic disease is a chronic disease when liver is sick for a long time, so therefore a depletion of production of albumin, and there is a because of inflammation of production of globulin is high, leading to a reversal of AG ratio. So anything where there is a reversal of AG ratio, there is a chronicity involved. Now hemolytic jaundice, as you know, the main problem lies with excess overload. There is lots of RBCs destroyed, hemoglobin is degraded, that huge amount of bilirubin is produced, liver is unable able to conjugate them. Liver, it goes beyond capacity of liver. So what will happen here, you will find a very high unconjugated bilirubin as well, but all other features are normal because there is no abnormalcy in the liver. Liver cannot cope up with the excess workload. Here, there huge amount of blood is dealing, and therefore a good amount of bilirubin is come up. Liver cannot actually deal with it. So you will get a high bilirubin, and most of them are unconjugated bilirubin because bilirubin could not conjugate it. But rest of the functions are okay because there is no functional deficiency of liver. It is because of overactivity liver could not produce. This is another one, obstructive jaundice or hepatitis. So what happens in case there will be total bilirubin raised and most of them are conjugated bilirubin. And there will be a sharp rise of alkaline phosphatase and GGT. You may get a reduction of all of them or may not. AG ratio remains usually normal. Prothrombin time will be high. Here the reason of prothrombin time high is slightly different. Here it is because of the clotting factors could not be produced. Here it is because of the vitamin K deficiency. Because as I told you that bile cannot come in the gut and it happens so. One more striking feature is there, it is not mentioned here. Urinary urobilinogen will be very high in case of hemolytic jaundice and with almost zero in case of obstructive jaundice. I'll give you some cases. First case 1 is the total serum bilirubin 9.8, conjugated 5.3, unconjugated 4.5. If you see that there is a striking rise of ALT and AST, and there are urobilinogen positive, bile salt, bile pigment, all are positive. So what is this? This might be a case of viral hepatitis, where initially this is what a hepatitis or acute hepatitis. Now this is case 2, where you will find the total bilirubin is very high and unconjugated bilirubin is mostly high, and rest all are normal. Enzymes all are normal, which signifies what? That means the liver condition is okay, but excess bilirubin is mostly unconjugated and urobilinogen is very much positive. That means the jaundice is due to overproduction of bilirubin or overproduction, over-destruction of RBC. So we call it a prehepatic or hemolytic jaundice. And then it comes, here we'll see total bilirubin full 12.6, conjugated 12. That means it's a conjugated hyperbilirubinemia. Along with you get a specific sign of very high AST, alkaline phosphatase, very high GGT, and almost normal AST/ALT, and urinary urobilinogen is not present. So this gives a clear picture of a obstructive jaundice. These are the some cases I have given, and just you go for a diagnosis. Because you may think that liver function test is very straightforward. Now, if I give you these 3 pictures, how will you interpret? Let's see. This bilirubin is 3.9, direct bilirubin 0.5. That means mostly unconjugated. You will get this AG ratio is more or less similar. So this is a clear-cut case of what? Hemolytic jaundice, isn't it? Now, this is the second case where you will get a patient 3.5 to direct 1.2 is a mixed pattern, slightly raised alkaline phosphatase, and AG ratio is arbitrary-reverse. And you mind it here, this AST and ALT ratio, you will find AST is much higher than ALT. The ratio is here is more than 1. So it goes more in favor of a chronic hepatitis or chronic liver disease. Second, 3.2, 1.2, you see alpha phos more or less okay. Here, the OTPT ratio is again normal. The ALT is much higher than AST, and the liver enzymes are more or less similar. So it is the just very initial phase of hepatitis. So this is what? This is the initial phase of hepatitis, or acute hepatitis is just initial phase. This one is a chronic hepatitis. How you diagnose this? Looking at these ratios. Because other features are more or less same. Here it gives you a guide that this First of all, it's chronic because AG ratio is reverse. Secondly, OTPT ratio is also more than 1. Here, OTPT ratio is more or less than 0.5 and these are normal. So here, through this we can get a diagnosis. This one is a hemolytic jaundice. This one is the chronic hepatic disease or chronic hepatitis. This one goes more in favor of a acute hepatitis right from in the beginning phase. Now you see the case 5, a very, very interesting one. You see total bilirubin, patient 1, patient 2, patient 3, more or less, all are more or less similar. So how do you differentiate these things? In patient 1, it is alkafras 108-14. SGOT is very high. SGPT is slightly high but more or less normal. Total protein AG ratio is more or less okay. This patient is very borderline. You cannot call it a jaundice, where direct bilirubin is mostly normal direct bilirubin. No much difference is noted. Second patient, the same kind of borderline hepatitis. Alkaline phosphate is normal, but OTPT ratio is very high. SGPT is much higher than SGOT, and AG ratio is more or less similar. Now, in the third case, you will find all are more or less okay. Only the GGT is very raised, but OTPT ratio again is more than 1. So, how would you interpret this case? So, these are more or less, you can look at it. The first patient is basically not a hepatitis patient at all. This particular SGOT, rise in SGOT, most likely happened because of either cardiac injury or muscle injury. So it's not a patient of liver injury. It's a patient of either cardiac injury or a muscle injury. Second patient is obviously a case of acute hepatitis just in the beginning phase. And the third patient is actually a alcoholic liver disease patient. So you see how similar all the LFTs look like. You have to be very minutely observing these cases. One thing I actually forgot to give a case in this scenario is that sometimes you may see that a bilirubin has been 1.2 or 2 and AST is 1500, ALT is 3000. And you have diagnosed the patient as an acute liver disease or viral hepatitis. So after 1 week, you have found that the bilirubin has gone very high, but ALT-AST has went down, and you'll be finding it difficult to actually explain to the patient. What happens during the phase? You have to keep it in mind. During the phase of initial acute hepatitis or hepatic diseases, hepatocytes ruptures and therefore good amount of enzymes come out in the blood, leading to high enzymatic activity, but still some portion of bilirubin conjugation mechanism is still on. So you will not get much effect on hyperbilirubinemia. With time, the liver injury gradually comes down, but by the time liver metabolic functions are depressed. So you will find with long run, initially bilirubin slightly raised, enzymes are highly raised. Then enzymes are coming down, bilirubin is going up. This is sometimes a patient come with anxiety. Why my bilirubin has increased? You need to explain them that in the secondary phase, bilirubin goes up and enzymes come down. That means the liver is getting healed. Gradually with time, now bilirubin will also come down with hepatic enzymes. So hepatic enzyme rises first, and then when it comes down, bilirubin rises then, and then both the things come down on a healing process. So this is, you have to understand when you are actually interpreting or diagnosing a case of liver disease. So these are very simple thing, but yet you have to give much of your intelligence to actually interpret when the cases are very borderline cases or confusing cases comes like this. Thank you for listening. I hope you are subscribing my channel more and more so that we get more and more model to deliver one after another cases. So we'll now talk on one or two baseline things. After that, we'll go for advanced technologies gradually. I hope you like it. And if you have any questions, you can comment on our inbox so that we can later on answer you from there. Thank you.